looking to do a study about my CKS experience for the last 20 years, we didn't know how many of these people we could get in touch with. I'd done well over 1,000 of these joints, in addition to the other manufacturers we were using simultaneously, but weren't able to get in touch with them because of those exact reasons we talked about. And I first began using the CKS joint because I had failures with other implants. My guess is you guys all have heard about the things in the past. And so we were looking for an implant company that had never had a recall. Do you guys have any idea how few of those companies there are out there? I mean, nearly zero. But there was one company at that time, it's called Hayes Medical, which became Consensus, now shall be Advanced Technologies, and their CKS knee had never had a recall. In fact, the entire company had never had a recall at that point, and here we are 20 years later, the company has still never had a recall. So at least I had that one issue I wouldn't have to deal with. So we're able to pull together a group of patients. Our criteria was at least a minimum of 5-year follow-up. We want to have direct personal communication with them or the representative in order to count them in the study. Our specific purpose for this study was just survivorship. We wanted to know how many of these patients were still in the original joint without any additional surgery whatsoever for that CKS knee. So it's a single surgeon experience, just me, the 10 years between 2007 and 2017. There's a couple of reasons we didn't go back before 2007, even though I'd used the implants before that, and that's because number one, the implant was going just a little bit of revision for the style to what's called a reduced lateral profile for the femoral side, because the others were a little bulky at proximal. I don't even know if that's even available anymore. And the original instrumentation from 2004 wasn't as user-friendly as we would like. So the company very graciously changed some of the instrumentation to my regard, and now I think they've adopted most of those changes to the instrumentation at large. So it's a single community-based private practice, just me, no residents or fellows, my hands did all the surgery, single hospital system, same instrumentation from 2007 on, and we did not use navigation of any kind. So we're able to find 441 primary total knees, or examples thereof, in 247 patients that met all the criteria involved. And because we went through two different changed practices, and we had two different electronic medical systems along the way, it was very difficult to find these patients, but we're able to find the 247 knees, average follow-up of just under 9 years. Because we can get in touch with them, we did COOS scoring, and all of our scoring was very good. The patients, 99% of the time, returned to their functional level of activities, their desirable functional activities, including sports. Most of them were like tennis or golf and things like that. Satisfaction score was 94%, which actually surprised me because that's better than the national average, as you know. I'm quick to quote a statistic. You know, internationally, they tell it 90% of people who have a knee replacement say that they are 90% better when you question them at a year. Only in America, I think, the satisfaction score is 80%. That means there's 10% of the people out there in the US that are 90% better or more, and they're still not happy. So we have our level of expectations are just through the roof. But the satisfaction score for these particular group of patients is 94%. And the survivorship also surprised me. 97% of the people at 10 years had never had any additional surgery or failure. In the history of the company, to the best of my knowledge, there's been one implant that wore through and had to have the polyethylene replaced. How do I know? Because it was my patient. Promptly after we did her knee replacement, she gained 100 pounds. She had a size 1 tibia and ultimately wore through the polyethylene, and we swapped that out a couple of years ago after 14 years in situ. Instability was only a problem in one particular patient which required additional surgery, and that's because she popped her PCL because I'm a posterior cruciate retaining surgeon. So the reoperation rate overall was 3.2%. We're pretty happy about that. So the observation about the system in general, it's a very surgeon-friendly system, very reproducible results, and with the new instrumentation which we developed now, 15 plus years ago, involves minimal bone resection, and the x-rays that come out, generally speaking, if you follow all the guidelines, they look like they're robotically done. Very, very reproducible. Very happy with it. So tips for success. You heard people talking about people who have flexion fractures and people not having good motion. So I use the 8 to 13 millimeter distal cut algorithm. A natural cut is 10 millimeters, but if somebody has a little hyperextension, I cut a little bit less. Somebody has a flexion contracture, I cut a little bit more, but I don't take it all off the femur. The biggest femoral cut I'll typically make is 13 millimeters. The cut should be flush with the anterior aspect of the cortex, have the best bone to fit it to up there, but you don't want to notch that anterior cortex because, you know, as little as a 3 millimeter notch increases the fracture rate by 3-fold. We always double check the tibial alignment. So whether you do a freehand cut, which I saw Dr. Patel do the other day, it was amazing how accurate the guy was, but if you do a freehand cut or an eyeball cut, you always want to check that though and make sure that your varus valgus alignment and then also your pitch. You want to make sure that that posterior slope's going to match so that you don't bind up in inflection. So we always, whether we use instrumentation cuts or freehand cuts, we always check that with a final implant. It has a way to do that. We always clean out the posterior space because that's where people come back in with sometimes with posterior or posterior medial, posterior lateral pain. You want to make sure that you took out those osteophytes, the meniscal remnants, and any debris that's back there. Because then at least you know in your mind, if it didn't make a difference, because some people say it doesn't, but if it did make a difference, you know in your mind that you clean that out and that's not the source of their pain. But I think it makes a difference to clean them out so that you have nice excursion of that tibial polyethylene over the posterior aspect of the condyles. Just be meticulous with the cement cleanup. Nobody likes to come back and get an x-ray to see cement particles in the joint somewhere or adjacent to the implants. So I happen to use an inset oval patella, but whether you use it's the only reamed oval inset patella on the market, so you get better coverage. Somebody obviously has a round patella, you're going to use a round patella. But you always want to make sure that patella, whatever technique you use, has a midline, no thumbs tracking. Because nothing is worse than the patient coming back to you and they're showing they have a J tracking or they're not happy because the thing is settling. So if you're very careful making sure that patella tracks well, you'll have happier patients every time. And that's my experience, 20 years using an implant from a company that's never had a recall and never been happy with my results. Now, thank you very much.